Hello, my name is Laura Adang. I'm an assistant professor at the Children's Hospital of Philadelphia, and it is my pleasure today to talk to you on a topic that I've been working on for several years now, on the use of biomarkers and also the Baricitinib trial data. And hopefully you can learn some today with me as we discuss the data from our Baricitinib trial and how biomarkers have been used and how they could be used in the future. I have a few disclosures to discuss. First of all, Eli Lilly did provide the support for the drug and safety monitoring, as well as the PK studies that were part of our repurposing strategy. The AGSAA also provided some support for these studies, and we have several sources of NIH funding. On slide 3, I think it's important to understand what is a biomarker, right? And we use this term a lot, but oftentimes we're using it incorrectly. A biomarker is just simply something we measure to indicate a process. It can be a normal process, a pathogenic process, which means part of a disease, or even a response to a treatment. So an example of these is really anything. It can be molecular, meaning something we test in a lab, histologic, meaning a picture of cells, radiographic, meaning a picture of the body, or physiologic, something like heart rate or blood pressure. And these are just characteristics of a biomarker. Some examples of biomarkers that have gone through the formal regulatory process, which is qualification, include blood glucose as a biomarker for diabetes, or tumor size that they use in the cancer world, or blood pressure, which you can use to measure as a biomarker for hypertension. In AGS, we talk a lot about diagnostic biomarkers, which are things that we measure that help us make a clear diagnosis of Aicardi-Goutières syndrome. More generally, from the FDA's terms, a diagnostic biomarker helps us to confirm the presence of a disease. It helps us to identify individuals that even have a subtype of disease. So an example of a qualified biomarker is blood sugars in diabetes, right? We know that helps us to diagnose diabetes in the first place. In the AGS world, we oftentimes do struggle with diagnosis. It's a combination of genotype, and some of the biomarkers that we have in clinical history help us to understand or give the label of AGS. Biomarkers in the AGS world would help us to make a diagnosis and even potentially predict the future by allowing us to put children into a subtype. We really need qualified biomarkers in AGS. And while we use CSF, neopterin, and tetrahydrobiopterin as biomarkers, they have not been qualified for this. And we also use the ISG score, which we'll talk about in depth later, as a diagnostic biomarker in the lab. But again, that hasn't been qualified. It hasn't gone through the level of rigor that we really need it to have gone through. So there's potential biomarkers in the AGS world include ISG scores. They've been used for actually quite a while now. And when you look at a group of children that have AGS and you compare those to those that don't have AGS, you can see that the ISG scores are much higher in kids with AGS compared to those that aren't. But when you look at genotype or severity, there's not really a good correlation, meaning that's an area for potential development. It would be really special to have a biomarker that helps us to understand the disease process, not just presence or absence. So what about another area where diagnostic biomarkers are really important? Like on the newborn screen. Like, how do you diagnose someone with AGS before they have all the clinical symptoms or even the molecular information that can help us to diagnose them? Well, there was at least one pilot study using ISG scores in the of children that were known to have AGS and looking at their levels on the newborn blood spot. And they were elevated in most cases, but not all. And so it becomes really important for us to develop and further look at better or different biomarkers in this context too. I like the ISG score to help discriminate between AGS and non-AGS, but there is room for improvement. It's not perfect. So I think a fundamental question is the ISG score, or that interferon-stimulated gene expression score, the thing that when you have the cascade of interferon stimulation, it turns on these mRNA, all these genes, and we measure the mRNA, and that's the ISG score. But it's really an indirect marker of a cascade. Is there something more specific within that pathway? Maybe something that doesn't change as much moment to moment, or something that is actually proportional to genotype or severity. And so we're looking in general at various other places in the pathway that might be a more sensitive or specific place for us to understand how AGS is affecting kids, but also make that fundamental diagnosis. There's another area of biomarkers that's really important in AGS, and that's called a response biomarker. A response biomarker, and this is the FDA language, is a biomarker used to show that a biological response, either good or bad, has happened from a treatment. And so with a response biomarker, we're looking for a couple different things. One is a pharmacodynamic biomarker. That means I have a sign from something that I measure that the drug reached its target. And we'll get into it, but the ISG score has been used as a potential pharmacodynamic biomarker. Does it show that the child or the person received the medication at all and it hit the right spot? This is not the same as efficacy. That's really important to distinguish that. A biomarker just measures something very simple, right? Like, did it hit the target? When you're starting to talk about efficacy or how well a treatment works, you're getting into something called a surrogate endpoint biomarker. There are actually very, very few biomarkers that have been validated as surrogate endpoints. They directly represent, in a very reliable fashion, how a patient feels, functions, or survives. And so one example is MRI pictures in multiple sclerosis. One would think that multiple sclerosis, which is an acquired demyelinating disorder primarily of adults, we do treatments based on how the MRI is changing. And so one would think that an MRI would be a really good surrogate endpoint. But it's not true. Sometimes people worsen even though their MRIs don't, or vice versa. The MRI has changed, but the patient looks the same. And something like multiple sclerosis, which is overall much simpler and better understood than AGS, even MRI can't be used as a surrogate endpoint biomarker. And so it's something that we're always looking for, but it has a very rigorous level. An example of something that's a successful surrogate endpoint is hemoglobin A1C levels in diabetes, right? It's very simple to measure, but it's a really good measure that reflects how a patient will do months to years later. And that's been validated and formally qualified. In AGS, we've looked at a lot of different potential therapies. There have been multiple different Janus kinase inhibitors, both baricitinib and ruxolitinib, that have been tried, as well as reverse transcriptase inhibitors. And biomarkers, as I said, can help us determine if a drug has reached its target, which, right, did it even get to the cell? These are important questions. In the context of our baricitinib study, we in total treated 38 children, 35 of whom had molecularly confirmed AGS, with baricitinib. And we followed them now over 5 years for some of the subset, but at the time of publication, we had at least 12 months of data on everyone. In our cohort, we had a good mix of genotypes representative of the population of AGS. And I want to point out that the mean age at onset was less than a year, which is consistent with what we know about AGS. Children tend to start having symptoms early, but the mean age at treatment was actually closer to 6 years of life, showing that there was a huge difference between when kids began to have symptoms and when they were started on study. We monitored change in these children on therapy using a variety of different approaches. One was a clinical score where families filled out a daily diary saying how AGS was impacting their child. And we found that the scores did improve over time. So between the very first diaries, which were completed before study, compared to the very last ones, there was a statistically significant difference between first and last, meaning the diary scores were improving. A really important part of AGS is the skin inflammation that can go along with it. And we looked at how skin was changing over time. We found an overall improvement in a subset of kids where skin findings or inflammation were less severe on study compared to before study. And anecdotally, there were several examples as shown in pictures here where the skin dramatically improved after treatment. We were interested in the bigger picture overall neurologic trajectory with treatment, and so we looked at a simple measure of developmental milestones. Before children were treated on study, we measured how many milestones they gained. Compared to the first 12 months on study, we looked at how many milestones that changed. And we found that in the 12 months on study, children were gaining more new milestones compared to before. So our models, as shown in C, which was the QLS model, showed that approximately 1 to 1.5 new developmental milestones were gained on study that likely would not have been gained without treatment. Another way to look at it are the plots on the far right, where you can look at the change in milestones before treatment compared to after. Before treatment on the top, many children either were stable, meaning a change of 0, or actually had lost skills in the 12 months before study, compared to most children actually gained new developmental skills while in study. This was done through post hoc analysis, meaning this wasn't the first question that we had, and this was actually a question and a scale that was developed because of the trial. So it's not as rigorous as if we had started with the same question. We were interested in knowing how much the amount of baricitinib children received changed their response. And we have found that when children were on a higher dose of baricitinib, typically in the younger kids, we were able to reach that milligram per kilogram goal. We found that those children did better and had greater improvement, suggesting that there was a dose response, meaning children that were appropriately dosed did better than those that were underdosed. There are other types of biomarkers as well that need to be explored in AGS. One is called a response biomarker. A response biomarker is a biomarker that is used to show a biological response, either good or bad, has happened after treatment. For example, looking at heart function with ECMO, which is a way you can give oxygenation outside of the body. Or, again, that surrogate endpoint, such as hemoglobin A1C in diabetes. I think the ISG score, or that interferon gene expression score, has potential for a pharmacodynamic biomarker. In this case, this is our study data. If you look at baseline, that's untreated, we found that when baricitinib was added, the ISG scores dramatically decreased, but they actually continued to increase. So if you look at the average, there was, in the next year, actually a recalibration of where the ISG scores were trending back upwards again, even though, if you remember, kids overall were doing better. And so that's that important disconnect. While the ISG score did a pretty good job at demonstrating children received the baricitinib, it wasn't really proportional to how they were doing in life. On the right panel, you can see a heat map where we can see those ISG scores. The higher they are, the warmer the colors, so the reds and the yellows. And the blues and the greens are representing ISG scores that are closer to normal. You can see on study, which is on the right, there's more blues and greens, right? But you can see it still goes up and down. The ISG score is really quite dynamic. And on the next slide, it explains part of why. ISGs are actually naturally produced in response to infections and vaccination. And so here's an example of 2 different patients that were treated with baricitinib. And they had ISG scores tested after vaccination, after febrile illnesses, urinary tract infections, sinusitis, and you can see it goes up with these life events. That's a totally normal response to have happened. And so ISG scores are really helpful to measure in AGS, or they at least have the potential to, but they're also very dynamic moment to moment, depending on what's going on in the life of a child. There are other types of biomarkers, and one of which is called a safety biomarker. Safety biomarkers help us to measure how safe a treatment is, right? And so it's like measuring liver function after a treatment. In general, safety biomarkers are not specific to a disease, but really are organ specific or relative to the body. And so in the Baricitinib trial, we were able to use safety biomarkers that have been validated and qualified for other indications. And we looked at things like liver function and blood counts to see what was changing when children were being treated with Baricitinib. You can see that we did odds ratios, which is a way to calculate the risk or the likelihood of having a change. And we found that children's platelets were going up, their hemoglobin or anemia was going, they had an anemia or their blood counts were going down, and they had a neutropenia at higher than before. And so a neutropenia is a blood count that helps you to fight infection. And so these are the things we're going to be watching very carefully as we treat more children with Baricitinib. On the next slide, you can see our conclusions. We found that overall Baricitinib was very well tolerated in AGS, but it requires careful monitoring, especially with attention to the blood counts. Based on the interferon signaling gene scores, we found that there was target engagement, meaning when we treated with Baricitinib, the ISG scores went down. And we found Baricitinib had an effect on the following clinical parameters. We found clinical scores improved, skin manifestations improved, and overall, there was a trend towards neurologic improvement as well. I think that this supports that Baricitinib can be considered a disease modifier in AGS. And I think it's important because it offers proof of principle that this is a treatable disorder. Again, the children in the study had the disease for average of 6 years at the time they were started. And on the next slide, you can see some next steps, right? So I think the big questions that are outstanding are, who would benefit from Janus kinase inhibition? When should we be starting therapy? Should we be starting them earlier, later? When should therapies be stopped, and how do we do this safely, right? We know kids' interferon scores go up naturally when they get sick. And potentially that's not the safest time to stop a therapy. And we also, hopefully have convinced you, need biomarker development and qualification. This is that formal process from the FDA to say that a biomarker really represents what we're saying it represents. There are other types of biomarkers that I think are needed in the AGS world, and we're working on developing these. One is a monitoring biomarker. That's something that you test repeatedly in order to see if there's any evidence of exposure to a medical product or an environmental agent. For example, PSAs in prostate cancer, right? You measure this serially to see if you develop cancer. Is this something where an ISG score, another inflammatory biomarker, could be used in AGS? On the next slide, we talk about susceptibility and risk biomarkers. This would be amazing, right? This indicates the potential to develop a disease. And so, like BRCA genes in breast cancer, could we have an indicative biomarker that lets us know a child is at higher risk or lower risk for developing a complication from AGS? That would be a really helpful thing to have both in the clinical world and in research. And on the next slide, we talk about prognostic biomarkers. These indicate the likelihood that an event is going to happen. A disease will recur, there's a progression. So PSA and prostate cancer for the return of cancer. But you could imagine, wouldn't it be really powerful to have a biomarker that I could measure that says a child is at risk for having a flare or developing AGS in the first place? I think having a prognostic biomarker would really be valuable. I'm also interested in predictive biomarkers. These are used to identify individuals that are more likely than other similar people without the biomarker to have either a good event or a bad event after a product. This is, how do I predict who really is best suited for Baricitinib versus a reverse transcriptase inhibitor versus another type of novel developed therapy, right? Who's going to benefit from this? Because I don't want to expose children to a medication that doesn't potentially help them. And so a predictive biomarker helps us to do this. So, in conclusion, I'd like to acknowledge our very large and wonderful team of people dedicated to helping better understand AGS. And it has been my pleasure and honor to speak with you today.